So my name is Jody Shevins, and I am a naturopathic doctor. I'm in Longmont, Colorado, where this morning it was 25 degrees and now it's 70. It's kind of a cool thing about living here. And I have been in practice as a naturopathic doctor and a classical homeopath for 38 years. I have grown children, and I have had thousands of homeopathic visits with children. And the fantastic thing about that is that I treat the children of the children I've treated. And so I have this long arc of thinking about the role of homeopathy in our lives multi-generationally. And so that's what I want to bring to this talk this evening. When I first learned about homeopathy, I read Vithoulkas's book, The Science of Homeopathy, and I thought, wow, if this is true, this is like we could really change the arc of a person's life. Like, what if you're always adjusting the vital force from the very beginning? Again, I'm just going to ask again if everyone could mute themselves. That'd be great. Thank you. But what if we could do that? And I have to say, after all these years, I don't know. I don't know if we do it, but I know I help. I don't know if I do the thing I wanted to do, like, make society better by making happier, healthier, more altruistic, functional people. But I sure have given it a good go. And what I want to do tonight, this lecture is not a basic lecture. I realize I don't want to teach, oh, this is how you take a child's case. I want to teach, I'm assuming you know that you take the case, you look at the generals and the particulars and the concomitants and the modalities. And although I'm going to mention those things, it's not where I want to linger. I want to linger on what I've learned all these years about how to get a good case. Again, please, would everyone please mute as you're entering? Please mute. Thank you. I want to share my experience with you. I want to share with you what I've learned and what I think matters and how to get a good case and what it means to get a good case. And I'm going to present a few cases. And I was just thinking about who I've been seeing recently, and I picked some that I think are really illustrative. And so that's my goal. What I want to do tonight is look at some of the subtleties and talk about the different phases of youth, pre-adulthood, and just share my thoughts with you and hope that you'll all become better prescribers because of it. So, great. I think I need this might get in the way, but I'll leave it up for a minute. Okay. So first I want to say, okay, well, what is childhood? Infancy, typically people refer to the first 12 months. Oh, and if you see this, I did break my arm. That's why it looks weird. Gets icy here in Colorado. So infancy, I'm going to talk about basically roughly the first 12 months. Childhood being the period between infancy and adolescence. And adolescence, the complicated one. It was that transition stage between where we're growing and developing, between puberty and adulthood. So typically 10 to 19, but there are some cultures where the 4-year-olds are caring for the younger child. And there are some cultures, kind of like ours, where the 30 and 40-year-olds are just finishing growing up. But I am talking about this phase of childhood in the more traditional way that fits these definitions. So I'm going to make this small now. To prescribe for children, there's certain things that I feel very strongly about that you have to understand. You have to know what's normal and what's abnormal for different developmental stages. People who act like 2-year-olds who are 40 usually seem psychotic. But in a 2-year-old, we think this is normal. So understanding what's normal and abnormal for developmental stages is just like understanding what's normal and abnormal for the course of an illness. And this way, if you give a remedy and they're 6 months old and their teeth come in, well, they were going to come in anyways. Or if you give a remedy and a cold normally lasts this long and they get better, is it the remedy or is it just the normal course of the illness? So it's very important if you're working with children that you understand what's normal for the different developmental stages. Also, something I feel very strongly about, and I'm going to be, forgive me, a little repetitive at, is the medical risks of their symptoms. Practicing a long time, you kind of see everything that can go wrong. And, if someone's got a fracture or a child has diabetes or they've got a tumor, it's really important to understand what the risks might be of the particular symptoms that they present. And so we'll come back to that, but that is extremely important when you are providing healthcare. I think it's really important to understand what's necessary nutritionally so that we don't confuse nutritional deficiency with what's the remedy. I mean, a similimum can certainly help people optimize the use of their nutrients, but proper nutrients, a remedy will not take you can't do it instead of getting enough nutrition. And this business of knowing the limits of your knowledge, knowing when to refer, when to get diagnostics, when to know what you don't know, this is true at every level of knowledge. So it's just so important with the children. The big controversial button, you need to know the laws and the science around vaccination where you live. I don't really want to go there tonight because it'll dominate the whole talk. I am someone who does believe in vaccination, and it's important conversations to have and right use. So, stay with me anyways, if you're not. Very important to know the signs of abuse and neglect and when and where to report these things. If you're in the role of healthcare provider, then it is on you to know these things. So I want to talk about communication, because with children, that one of the differences with prescribing for very small children is they haven't developed all their language skills yet. And so they can't just tell you what you want to know. And it might be a fallacy that we think even the adults can. Again, I'm going to ask everyone to mute, please. So part of being a good receptive case taker is to have an intention that you're going to notice what they're communicating. You're going to perceive and understand what you need to know. And I would start by setting your intention. That what I wrote here is be open to what they're experiencing and what they're communicating in all the ways that a living being communicates. So the first thing is to adjust your mind and your centeredness and your receptivity and your intelligence, your openness to everything they're expressing. And I think with children, those two questions, what are they expressing? What are they sharing? What are they telling you? And what are they hiding? And children, and a lot of them, they're hiding things. They're not always that good at it. But to notice both is going to be enormously helpful. So you notice all the typical things, what's their facial expression? How are they sitting? If they're children who can choose their clothing, what did they choose? So interesting. I remember the little boy, he must have been about 9. He wanted to be a newscaster. And he went everywhere in a little suit and a little tie, and he had a little newscaster hairdo, and he wore that to school every day. I mean, it's a lot right there. Or the little girl who wore like 10 layers of clothing, like it's great watching what kids wear. their art, how do they move, what's going on in their eyes, their discomforts, their pleasures, their actions, their emotions. Of course, I assume you all know these things, but you just have to keep asking yourself, what are they communicating to you? What do they want you to know? What are they saying to you? And I don't mean with their words, with or without their words, but then here's the caveat. You have to avoid making up a fiction about what they're communicating to you. If you have some ideas, oh, they're saying, oh, I just love to jump up and down, or I love to eat, or I love to sleep, or I hate everybody, or I want to kill you, or whatever they want to say. Just make sure, it'll come back. It'll come around. If it's true, you're going to see it in other ways as the case goes on. Yeah. So I used to think that when you prescribed for a baby, and I even taught this, I a little bit regret this now, that it was kind of like prescribing for pets or something, that it was all observation. But I really don't think that anymore, because a young human is the amazingness of a human being with everything that goes into who we are in an immature state. And there's a lot going on in them. And I want you to, as I say, listen and look for that human being who's in the baby. Because I think once you ask that, if you're not, if we're not hallucinating ourselves, you're going to have answers. And so in some ways, maybe this slide is the most important thing for me to say to you about how to take the case of a child, to just quiet yourself and open yourself to the fullness of what they're saying to you. Okay, so I'm going to talk about the these three different phases in acute and constitutional to some degree. So if we're prescribing for an infant, a little baby, first of all, like in the state of Colorado, as a naturopathic doctor, only some of us are allowed to even treat infants without other training and other continuing ed. So it's not for everybody. You have to know if it's right for you to take it on. And so if it is, about infants, and you are aligned with people who do, you're working with people you do, then fabulous. And so if you're not trained, then make sure you're associated or working with someone who is. Back to this business of diagnosis, it's very easy for something to look like an ordinary baby problem and it not be one. So I don't mean to scare you, and I do mean to scare you. I mean to ask you to just really have integrity about this, that you want to make sure you know what the problem is, and if it could be something dangerous and time sensitive, that you can be someone who can intervene and make sure they get the care they need. And that might be you. Probably the most common issues that people bring me their babies for are teething, sleep, digestion, skin, and then developmental and behavioral. But more those first four, people want help with it. And so most of these things, let's talk about taking an acute case for a baby. And so how do we do it? Well, the adult describes the problem and they tell you more about it. And often an adult will tell me what their infant is feeling. They say, well, they're in a lot of pain. And I want to say, well, how do you know they're in pain? So I want to start by separating their observation from their interpretation. Probably they're right most of the time, but I want to know how they know. So they have to back up a step, and they'll say, oh, well, they're squinching up their face and screaming, they're pulling their legs up, they're moving this way or that way. Like they'll describe exactly what they notice that leads them to the interpretation that they're in pain or they're uncomfortable or they're angry, or they're not always right, but they're usually right. Occasionally I've had people who they said, oh, they're really restless at night. And then really the problem was that they were really constipated and they were moving away from the discomfort or something like that. So make sure when they say what they've noticed that you separate them from that next tier where they've made a decision about the cause of what they've noticed. And as usual, just really, really specific. What makes it better? What makes it worse? I want to know if it's happened before, and I want to know what was going on at the time. Classic case-taking questions. So, but the next thing, when an adult brings in a baby, I want to know about what's fueling their reporting. If you have a first-time parent who maybe had very anxious parents, or you have someone come in and this is, their fifth child, or you have someone who wanted the child or didn't want the child, someone who's nervous, someone who's out of it. Like you want to know something about the parent and their reliability as a reporter or their bias as a reporter. Are they overstating the problem? Are they understating the problem? For those of you who have infants and you weren't the oldest of 10, or had children and you weren't the oldest of 10, because that's a different person, the first baby, the first time, everything can be pretty intimidating and frightening. And I remember saying, oh my gosh, is this poop normal? What about that eyeball? It looks too shiny. Versus someone who's like, okay, 10-second rule, it's fine, you can eat that. Always, if something's a physical problem, we need some examination. And this has been a real COVID Zoom challenge, learning how to do exam not in person. And it's been interesting. I have a lot of amazing photographs of all kinds of things. You can get a pretty good tonsil photo, though, I'll tell you. Certainly rashes, but it's very important to look at any problem that's visible, to listen to any problem that's auditory, to look, listen, feel. And in my office, I definitely, people say, well, can I change your diaper? And yes, you can. You need any information you can get is good to get. So exam, and as is appropriate to your skill set, or get the exam from others. And this other point, are there symptoms common for their developmental stage, not just for their illness, but also their culture? That there are big cultural differences in what we expect from children and how we treat them and what we think is abnormal or normal. And that needs, if you don't know the culture in the home of the child that you're taking the case, you need to learn about it or ask about it. And I made a little editorial at the bottom here that telemedicine has lowered the bar with physical exam. I don't want to get used to it. I got used to it and I don't want to get used to it. And I think I never regret looking at the person or being in the room with them. So the day I was thinking about this case, I got a phone visit. That's what PHV means in my chart. I got a phone visit about a 15-month-old girl. She's toddling around now, a little bit of language. And this is a child who's had COVID a few weeks ago and had a cough before that. So as many little children, she's had a series of illnesses. And this is what the parent says to me on the phone. She's had a runny nose for 3.5 weeks, and now she has a yucky cough. Everyone at daycare has colds. She has a cough at night. She's waking her up, a lot of mucus, irritable. I start asking some questions, but I just want to present what she said to me. This is really typical of a little phone appointment. She's teething, she's drooling, she's chewing. Mom's giving her chamomile. She's also giving her pulsatilla here and there. So now you can tell when I'm asking questions. I always ask, is she warmer or cooler than usual? She said she's warmer. She's more comfortable in lighter clothing than usual. And she says, oh, and she has this rash around her mouth, so not the acute. And her doc says it's from drooling and food. Ask about her thirst. She's always thirsty. She said, oh, and I've been giving her sulfur the last 2 nights and she's slept a lot better. So this is typical of a lot of very simple cases. I think because I've been practicing so long, I can hone in quickly. So what I know, or what you'd want to know, is, oh, she's had a runny nose. So we want to know, what does that mucus look like? And I can tell you, okay, this mucus was a little yellow and or thick or thin. The importance in this case is not so much the details, but what do we have here and what do we not have here? She says, okay, so she had this runny nose for weeks, but she hasn't been sick. Now she has a cough, a yucky cough. So the first thing I know about a yucky cough is I have no idea what a yucky cough is. So we need to nail that one down. So then we'd have to say, well, tell me more about the cough. And of course, that would be, when does she cough? When is it most frequent? Does anything make it better? Lying down, sitting up, having a drink? Does anything trigger it? Better in cold air, inside, outside, all the standard questions. So what mom means is there's a lot of loose mucus rattling around in her throat. You say, well, where is the mucus? And mostly people can tell you. They can always put your ear to the chest. And is it in the throat? Is it in the chest? Where's this mucus? And then everyone at daycare has colds. So we've just had 2 years of people not going to daycare and of children wearing masks everywhere. And it's been this wild couple of years of hardly any acute illnesses in children who are staying home. And so we can talk about whether that's a good or a bad thing, and we'll come back to that. So basically, she's got a loose mucousy cough. Nothing really makes it better or worse, except it's worse at night when she's lying down and wakes her. So much mucus now in her chest and coming out of her nose, and it's kind of yellow. The only thing I want to know is what's different since the cough started. That's the time period I'm focusing on. She's more irritable, but hey, then we learned she's teething. So is this a teething problem or a respiratory infection? The answer is both. Teething, I think of a little bit like PMS. It's a more immunologically vulnerable time where it's stressful, more likely to, or vulnerable to getting sick. But being 15 months old and going to daycare, one is likely to get sick. So she is teething, and I want to try and separate out the teething symptoms, the drooling and the chewing. And that's fine that the chamomile is helping with her irritability, but it's really not helping the cough. And so I'm going to back off of that. I'm going to have her back off of that. And the pulsatilla, mom's just given it to her because she thought it was a good mucus remedy. So I'm going to have her back off of that. The fact that she's warmer is significant. The rash around her face since before COVID, this is not part of the case, but it's interesting. And although, yes, it's from drooling and food, lots of babies drool and eat food, get it on their face, and they don't get the rash. So the rash is significant. So her own choice of giving her sulfur, I think, is a good choice. She's warm. She's warm. She's got yellow mucus. It was working. That was great. When I went through the symptoms, I came up with a different remedy. But for me, a short case often looks like this, but with some of the detail that I've been describing to you, the modalities on it. And so I think, okay, well, I've got an upper respiratory infection, probably not in her bronchi or in her lungs. She's definitely teething. What do I have to worry about diagnostically? She might have otitis media. She might have an ear infection. She might have bronchitis or bronchiolitis. It's really a case for, I don't like that her chest isn't being listened to. She's got a rash around her mouth, which is older. So the thing she's called me about is the cough, right? So we'll skip to the bottom here. Just If she had come to me without having given her the sulfur, I would have said Calcarea sulfuricum. And that's partly because I know something about the family history. I know that Calcarea is it's been a big family history remedy here. And that loose cough, the yellow mucus, calc sulf, you can read about, is a great remedy for this constellation of symptoms. I think she's getting a rash around her mouth because there's not enough oil in her diet. And I think she needs more oil. And in the meantime, if you put a water barrier salve, it'll help protect her skin while it heals, because it gets worse at daycare. So she'd already started giving her sulfur. So I said, well, you stay on the sulfur. And if it's not getting her all the way better, we'll switch her to calc sulf. But the other thing I said, if she's not doing better in 24 hours, she needs an exam. I don't want to wait around to let her get bronchitis and ear infections. So that's the diagnostics part. So I've mentioned some of the things that I think are what's salient from this is the risk of not having a physical exam. The fact that when someone says yucky cough, immediately you have to say, wonder what that means. That you have an alarm that goes off for nondescript descriptions. That you only look at the symptoms that are a change from normal. In this case, the mucus, the irritability, it might be the illness, it might be the teething, it might be both. To keep it pretty simple, this is not where we want to delve into the psyche of the 15-month-old, that usually acute prescribing in babies and children is simple and straightforward. The more you know materia medica and the more you're able to say, what's changed since the onset of the problem. And that's what you look at. Of course, your mentals, emotionals are the most significant, and changes in the generals are the most significant. Some backstory, I know that there's a multi-generational wheat dairy sensitivity in this family with relatives who had ulcerative colitis. And so the food piece might be pretty important. And this says all the more value if we can prescribe for her in a way that's really helpful for her acutely, but also constitutionally. This might really provide a future where she's maybe less vulnerable to those genetics. The fact that one of the parents is a smoker, even if they're not smoking in the house, this could be a player that's associated with more ear infections and a number of different problems later in life. So these are just things that we want to know about children. Those are more valuable constitutionally, but acutely, it's in the back of my mind. So I want to go back to talking about daycare. Children who go to daycare get sick on average once a month. The kids who go earlier, after a while, they stop getting sick all the time. We develop a certain number of antibodies and we get there. Most children, by the time they get to 10, if they're not unusually ill, have had the same number of illnesses roughly, or this used to be true. And so there's something about being exposed to each other and getting sick and getting better where we build an immune system when all is well. When all is not well, where children get sick and then they get pneumonia, or they get sick and they get some developmental delay, or they go deaf from ear infections. This is not ideal. I think to get frequent mild infections when exposed to other children, mild is the key word. My goal when children are going to daycare and all the other children are sick is to keep the illnesses short and mild. What I'm going to do is about halfway through the lecture, I'm going to take questions. So write your questions down. I'll take some questions before we get to adolescence. So taking a constitutional case for an infant. So those are just some of I want to complete the acute. I did not give you a rigorous explanation of taking acute cases for infants. Those are just what I think are highlights. A constitutional case of an infant, first of all, are they formed enough that you can even know? And should you, if they're not having any problems, are we going to tinker with the child on principle? And I want to say this is a question to think about in each case, because I'll often have people, they'll bring the child in because they want me to be there and take care of them as they're growing up. And so they want to establish the relationship. So they may or may not have any problems when they come to see me. Should I prescribe anyways? Like if I look at the family history and there are these tendencies onto the generations, if they seem perfectly fine, but I see some physical generals, should I just give them some sulfur or tuberculinum or pulsatilla or whatever the common thing that comes up? I will tell you, I often don't. If nothing's wrong, what I do is I create the map. I get to know them. I get to know their family history. I get to know their environmental influences. And then I am ready. I'm ready to care for them when they need it. Occasionally, I will give them something constitutionally. And it's always because I can already see the tendency happening. Maybe it's how they sleep or digest or respond to stress or triggers. So I would say in these situations, each time I would ask, decide. I'm just going to ask everyone to mute themselves, please. Thank you. That you decide. I don't automatically prescribe or automatically not prescribe constitutionally. I want to find a reason for my choice. With a baby, it's standard case taking. Of course, it's all history, observation, and exam. They're not going to describe to you, yes, doctor, when I poop 6 times a day and my little mustard poops, they're just pooping and usually, hopefully enjoying it. The history has to be deep and wide. You want to know about the pregnancy, about the birth, about the family constellation. Sometimes there are events during pregnancy that I think are relevant. I don't prescribe for fetuses. I certainly prescribe for pregnant mothers, but I can think of an example where a woman brought me a baby and the baby was having these really weird, high, sudden fevers, like really high. And it turned out during the pregnancy, she'd been in a car accident and she was terrified, the mother, terrified, thought they were all going to die. It was a dangerous car accident, but they were all okay. But she had this moment of terrible fright. And so I gave the child aconite and they stopped getting the fevers. So that's a cool little homeopathic story. But it also means you also have to rule out, is there an underlying reason for these high fevers? So you have to cover all the bases. So all our usual case-taking details we get. We do our review of systems. So how do we know the personality or the temperament of an infant? And especially if you've had children, we've all been an infant, but it's hard to remember for most of us. What we learn, and I assume most of you know, especially after you've had a few children or seen children, is that there's so much there from the get-go, from the time they're in utero, they're quiet, they're active, what affects them, and to the time they're born, assuming they're not having a pain. Pain obscures their temperament. But we know so much about them from the get-go. Babies are really different. It's people, especially new parents, they say to me, well, I can't tell if this is just how babies are or if this is how my baby is. And that's what we have to question through and really differentiate. And then there's this issue of interpretation. Again, like the parent will tell me, oh, they're so angry all the time. But they actually might be itchy or twitchy or having gas. So when they tell me an interpretation of what the baby is, I'm going to saying it again because it's so helpful. What do you see that makes you think it's whatever you've interpreted to be? And they'll tell you. the expression, the motion, and what's happening when it's happening. So personality and temperament, there's a lot of data right from the beginning. But if they are in pain, or if they have something if they have a brain tumor, if something there may be something physical that's obscuring or altering their natural expression, but you can just watch. So we get the generals, family and social context. This is very important because what's going on in the home, who they are, who's in their world, are their needs met, cultural differences is very important contextually to know their environment. So you must ask. And if they can't tell you, you need people maybe who know them. So getting this context is critical to getting a good case. Other things that you might want to observe that is unique when you're dealing with the babies is how the parents and the caregivers interact with the baby. Are they appropriate? Are they afraid? Are they affectionate? Are they oblivious? And something I have found so helpful, very often, the parents will come in and they'll have siblings. And I'll ask a question and the older brother or the older sister will say, oh no, they like to eat this and they're always doing that. And I like to listen to the siblings because I think they're usually right. So if you have a sister or brother giving you some data, you can ask the parent if they're accurate, because often those siblings are down there on the floor with the child and they can tell you some very special things. So take it all in. Make sure you're noticing everything that they're presenting with. Especially, are they physically comfortable? Are they physically uncomfortable? Babies are so interesting. Some of them, they just, they'll melt into your body. Others, they're rigid. So you want to observe all these things. Your history, things that the history of a child should include that's really part of your case when you're talking about an infant, of course, is your health history in the generations, all about the pregnancy, significant events, nutrition, all about the birth, family relationships, what's the environment, how are they doing with their developmental milestones, illnesses and injuries, what are they taking, vaccines, medications, other remedies, other supplements. Some kids come in and they're on a lot of stuff. And if you don't know what it is, you've got to look it up. What do they eat? What does the mom eat if they're nursing? What's their environment? Are there animals? Are there plants? What kind of heat? Is it forced air heat? Is there mold? Is there something in the environment that could be a player? And then I want to know about their parenting, the philosophy, the culture. Where are people coming from? I feel like I'm a servant to people. People hire me to help them achieve their health goals. I want to know their mission statement. And children, of course, can't tell me their mission statement. And the parents usually have a mission statement for them. And I just want to make sure they're safe, and I want to understand their well-being in the context of where their parents are coming from. So when we start to talk about children, I don't know about the inner life of infants, but when we start to talk about children, I got out of order? Okay, I'm going to back up. So we're going to go on to older children, older than infants, people who can walk and are starting to use language out loud. I want to understand who they are. I want to understand their inner life. So this is maybe a little out of order. Let's see. Okay. So when I'm talking about children, so we're going to children now. And I really want to understand children's, because the mentals of children are super important. And one of the things we want to understand is their inner life. I think that's the best way for me to say it. And that means they might not be able to say to you, well, I'm kind of extroverted, or I'm a little anxious, or I love color. Or the way I find out a lot about children is how they play. And sometimes after a first meeting with a parent, I tell them, I want you to watch their fantasy play. You know, when they got the little guys and the little characters and they're playing, at least, I don't know, my children, I raised them before the internet, really. I want to know who are the characters and what are they doing with each other? What are the dynamics of the fantasy characters in their play? Or if, you know, sometimes there's one, I want to say there might be one older sister who's saying, okay, you're the students and I'm the teacher, and you sit in the front and you sit in the back. And I want to know, what are they doing? So clues to understand the inner life of children is through play, through their art, through what they build, for what they like to do. Some children want to talk about their dreams, some don't. What they want to read, what they want to watch, who are their favorite characters, any way in to the things they think about and are drawn to that they're willing to share. I want to know. So this is something extremely important, because this will make and break the case. So case taking in children. First thing is that mindset. You want to be flexible. You want to be open. What doesn't work for me with children is to have a checklist. This is how I ask my questions. This is the order of my visit. This is how I do my exams. I have really good forms. I have them come in, fill out the history. I read it. And so I have some background. I already know the family history and the health history before they come in, and things about their habits and diet. I have a dietary. But then I want to know them. I want to find out who they are, because constitutionally, of course, it's going to be the strange, rare, and peculiars, the generals, and the mental emotional, so it'll be most helpful. So this stance where I start from the beginning of wanting to know who they are and what they have to say without me fitting them into a box. I am not on a search to find the remedy when I start. I am on a search to get to know them. I want to go into their world. I don't want them to conform to mine. I want to know about them. And so it's this mindset again of just opening yourself, letting them speak to you, letting them tell you who they are. Now, of course, one of the things they might want to tell you is that they're actually very hidden and they don't want you to know who they are. Just something to know. You also want to notice what's strange about them. If you notice something, you think, this is really odd. Don't shy away from it. Notice that you're noticing something. You have to notice a ripple in your own field. I've had children who were, I think they were probably dangerous and about to get more dangerous, very violent, cruel, most kids will hit and want to play knock it down, or not most, but many. And you just think, well, you're being kind of rough there and you need to teach them. And some of them I think, ooh, this is dangerous. We need big help here. But notice the things that maybe aren't like most children. No eye contact at all, very strange. Another thing I was thinking that really always I try and notice is when they're extremely precocious, where they're way more than most children are in whatever realm at a certain age. Children aren't that emotionally precocious usually, but they can be intellectually way beyond their years, which I experience for most children as a burden because they don't have the emotional IQ to manage it. They can be very physically precocious, children who walk and dance and balance really early. Sexually precocious, alarming, because one always has to make sure there's not abuse or inappropriate exposure happening. Very artistic children, sometimes extremely gifted children also have problems being in the world. And so I want to notice that and make sure we support them. And there might be early signs of mental illness. And I like to notice that early on, get them evaluated. Along with that, homeopathy can really shine for these children. So I want to ask the parents, because they're busy usually, and they want to tell me, oh, my child is, got rashes, or they don't sleep well, or whatever their problem is. But for me to understand them, they'll say, oh, they're really nice, they're really best, they're my kids, they're perfect, they're great, or whatever they think about their children. We all love our children, we hope. But when I ask them the question, to get beyond the mundane, I say, well, what's unusual about your child? What's unique? What makes them them? What's different about who they are? What's really outstanding? What's really central about them? That question opens the treasure chest. It really does. Because then if they haven't already thought about it, they sit back and they think about it and they say, well, what really makes them them is how much they care about other people, or how curious they are, or how afraid they are, or whatever it is. But that question is a real opener. Ask the parent, what are the qualities that make them uniquely who they are? And those words work. So this is the question: who are you? Who is this person you're seeking to take the case of? What makes them them? This is the doorway. This is the portal to some of the deepest aspects of this. Could be a 3-year-old, So I want to give you an example of a constitutional case. And the reason I chose this one, I'll tell you ahead of time, this is a calc-phos case. It worked great. He had his teeth were late coming in. They were really painful. But what I love about this case is how descriptive it is. And so I'm just going to quickly take you through it. And with the take home ahead of the point is how much you can know already about a youngster. So this is, 11-month-old. Is he a baby, a child? He's precocious. So he's in between. So I'm just going to go through it just to give you some ideas. He says, parent says, I said, well, tell me about him. He's a delight. His teeth are slow to come in, and they're really slow. They're really not coming in. His fontanelles are not particularly wide open. This is not necessarily a silica calcarea case. And most recently, he's basically waking up a lot and banging his head and whining and screaming. And whereas before he was eating at 3 and then 6 and sleeping, it was okay. Now he's inconsolable and needing to be rocked. His nervous system is different. And they were using Highland's teething tablets, and then they gave him Tylenol. That helped. So his cheeks are hot. He had a little fever. It's often common for children to have a little fever with teething. Doesn't have swollen glands. He doesn't really seem sick. He's very strong. He's unusually physically agile. He's muscular. He's a healthy guy. He's often gets angry. He's a very persistent, stubborn. He wants something, he goes for it. And this you'll see in small children and babies. Everything thrills him. He's looking at the birds. He's focused. This is not a delayed child. This is a slightly precocious child. And so that's interesting right away. I think, okay, well, he's mentally and physically precocious, but he's delayed with his dentition. So that makes it an outstanding symptom. He's got a little bit of a rash, poops a lot. He's eating everything. I wanted to know, is he eating anything differently? So this next symptom, she tells me, he's developmentally deliberate. So I see children like this. Some children just try everything all the time. He's someone who he starts to study what he wants to do. If he's got a new skill he's going to take on, and this could be like rolling over, sitting up, holding your head up. He studies it and then he goes. Like he's a baby on a mission. This is where you really need your baby gates. He's sensitive, he's curious, he's not irritable. So then that tells you all this inconsolable screaming at night, something's really up. He's slow to wake, he's slow to sleep, and then he sleeps deeply. And in his sleep, he kind of sleeps in child's pose. And he can rock a little like that. When he was really being uncomfortable and screaming, he wanted to be held and he didn't want to be put back in the crib. He moves a lot in his sleep and when he's awake. I gave them a remedy. I think I started by giving them Nux vomica, his determination, his drive, very ambitious baby, and all that irritability and screaming. And he was doing pretty well, but it wasn't holding. And so mom tells me more about him. She says he's 50% angel and 50% honey badger. Okay, I want to know about the honey badger. He says he scratches, he's quick, he's not gentle, he's aggressive, he's serious, he wants what he wants. He gets super angry and red and shaking. He's got a temper. And then on the flip side, this is the angel, he stands in the breeze and enjoys the sheer experience of it. These are his mom's words. I'm not interpreting them. This is the same one who's striking the birds in the sky. So he's got a lot of breath. His teeth are not doing any better. She, again, talks to me about his deliberate, intentional motion. She tells me he loves water. We go through his digestion. Bleeding around the anus can sound kind of terrible, but I think it's something about their hygiene, but I'm going to pay attention to that. This business, she said he ignored that he scraped his toes crawling towards something. He's tough. So this again, why is he screaming at night? I think, what's hurting him at night? She also tells me he's funny. He's got a sense of humor. He's making little jokes. He reaches out, he pokes you. A sense of humor in little children I see as a real sign of intelligence, and it's in your repertoire. He's jesting. See what happened here. I see. Forgive me. I have clearly gotten things out of order. Let me find the rest of this case. Oh, so I give him Calc Phos. It works dramatically. 6C. She gives him Calc Phos, and he sleeps. I don't know. And I would never say like a baby because a lot of babies don't sleep well, but he sleeps peacefully and without discomfort. And she kept him on that Calc Phos 6C for like a year. I didn't see her for a long time. And she said, well, if I don't give it to him, he screams at night. So I ended up, and his teeth came in after the Calc Phos too. I ended up thinking that it was something about his nervous system and his experience of pain, because we really went through to make sure nothing else was wrong. But like I said, I show you this case because it's very articulate and a lot is revealed. And what is most instructive in this case is the things that seem contrary and the importance of noticing them. Okay, so taking a child's case, what's important? I'm sitting here in my office this evening. It's my little pinwheel behind me. First of all, we know that what they say may or may not be true. And what's important is to make them comfortable, that the environment should be something you can clean. And so it should be safe for them in terms of microbes. It should be interesting. It should be comfortable. It should be child friendly and child safe, right? You've got child plugs in the outlets and no wires where they can eat them. But they should have opportunities where they can reveal or express themselves, toys to choose from, things that they can do something creative with. And I used to have a lot more toys in my office, and we'd clean them after they used them. And then when COVID came and we were washing our groceries, I took all the toys out of my office. Well, I also took the children out of my office, but I have brought them back. And I'm going to show you some of what I have here as an example. The other thing that's really important is you have to know, are we doing acute or constitutional prescribing? So you know where to aim your timing. These are some components of my office. This thing here, this is my fish. I've had my fish since 1986, and it's hanging from the ceiling, kind of right over here. And I've had adults who've come into my office, and they've been seeing me for years, and they say, "Oh my gosh, when'd you get the fish?" And all children who come into my office point at the fish. Like, I have to remember that the children are on the ground, and what do they see? The other thing is I've always had a little place for them. I got some unfinished furniture and did some fun stencil stuff. I did this more than 30 years ago. I've repainted it, but there's clearly a little spot for them, and they beeline for it. And there's my gallery. I love to keep some artwork. There's a little skier. I love my gallery. This is me. I've got a stethoscope on. So there's a place for them to go and sit and draw, write. I have things in here that are interesting. I also have secret things. There are things around the room that they find, and I don't tell them. I just let them walk around and they find them. So it's a place that's interesting to them, and they can look around and make themselves at home or not. And I can watch them. What they're doing, where they go is as important to me as what they say. So acute case taking in children is basically the same as adults, except that you have less accurate verbal instructions. So most of the details of the case you're going to get from their caregiver, and often the brother or sister. And their language, children use different language. A headache might be a sinus pain, neck pain might be a sore throat. So you have to find out what they mean. Often the parents say, "Oh, tell Dr. Jody, about your earache." Like, you don't know what to say. And so you have to make the difference between the suggestible child who I'll say, "Well, does your eye hurt? Does your throat hurt?" And then I'll say, "Does your elbow hurt? Does your knee hurt?" And then if they're just saying yes, 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 I realize I have no idea what hurts. A better question is, will you point to what's bothering you? Show me. Tell me what it feels like. Open questions, they may or may not be able to tell you. And it's important that when they tell you that something hurts, that it might not. So they can draw a picture, but usually we can figure it out. Just be aware that they may be an unreliable reporter. I'm going to peek in the chat. There was a practice management question. I couldn't resist looking. It wasn't necessary, and it's a long story. I'll come back to it. So acute case taking, the symptoms that matter most are everything that's different than normal. The things like that case before where they had the rash around the mouth, it wasn't different than normal, but it sort of informed my direction. A warm child with rashes, I would think sulfur. Their mood, their temperament, the generals, this is just basic case taking. So we're always looking for the changes in the generals, the mental emotionals, striking rare peculiars in acute and in constitutional, but very important. You want to know what's changed since the onset of the problem. So the next case I want to give you is a constitutional case of a 10-year-old. It's a very interesting and slightly complex and also very simple case, again, for an example of how much information can be there and how to filter through it a little bit. Constitutional case, this is a 10-year-old, and the problem is constipation. And I do the bulk of the case on the phone with mom. This is a 10-year-old boy, and there's a few relevant things to know. He has Down syndrome. And I'm going to just give you a little background. And he's had acute lymphocytic leukemia at 4 years old, and he had chemo for 2 years. So these are some pretty strong defining characteristics, that things to know if you're going to treat children who have chromosomal abnormalities. You have to know what's normal for them so that you're not treating Down syndrome, so that you're treating the child. And what's normal for someone who's had leukemia and got chemo for it, so that, again, you're treating what's unique about them, not their diagnosis per se. So something to know is that leukemia is much more common, childhood leukemia in children with Downs, and constipation and reflux are extremely common in people with Down syndrome. And undescended testicles, horizontal eustachian tubes, he's got sleep apnea. All of his problems are common in children with Down syndrome. So this case kind of rolls out the way it rolled out, the way I took it. I didn't go back and reorganize it. I've left a few things out, but I just put it in here because this is a constitutional case, because it's not acute constipation. It's a problem he's had on and off, and he's predisposed to it, both from the Downs and from having had the chemo. So she said his constipation, it came back full force. That means it was better for a while. He's changing his underwear 4 to 5 times a day. He's having bowel accidents. Often children who are constipated, there's so much pressure in their rectum that there's leakage. They can't control it. He had 2 years of voluntary bowel movements. So he went through chemo. So he was potty trained. He went through chemo. He got better from his constipation, and then it came back. So we'll go into why. So if he passes gas, he loses stool, and he's getting all upset going to the bathroom and changing his underwear and getting wiped. He doesn't like it. And mom says if she goes to the doctor, they just want him to take Miralax. It takes 3 days to empty out and don't know when it'll happen. It's socially inconvenient to having the Miralax blow out. She said the constipation started in the spring, and I'm sorry, he got better in this. He was better in the spring, and then when summer schools ended, this sentence is wrong. Basically, his constipation was better not being in school. And then when he got back into school, it got worse. She'd been using a lot of different laxative supplements, basically magnesium and different supplements for stimulating bowel movements. And she'd also used a lot of supplements for reflux. She had done that during chemo and then later. He's never had any bladder problems. He had a port in his body for the chemo, and he basically had to be tied down to have ports and injections and IVs and needles. And this made him angry and frustrated. So you see, mom's kind of moving around, and that's fine with me. That's why this seems random. There's ups and downs, whether he wants to go to school or not. He feels left out at school. He's 10 years old now. He's starting to be aware that he's quite different. And in the spring, he was saying, oh, people don't like me. And he stopped wanting to go places because he thought people wouldn't like him. And he's noticed that he doesn't read as well as the other kids. It's like he's waking up to his disability. Often children who have disabilities, they haven't noticed yet that they're different. And you get to 9 or so, 8 or 9, and most kids start to notice, oh, I'm not as smart, or I can't do what they do, or they don't want to play with them because they can't read social cues. Very tough spot. So then he's aggressive. Tell me about the aggression. He hits, he spits, he kicks, he scratches. He's violent, especially with his mom, sometimes with his father, with his para, and sometimes with other kids. So this is a really big problem because she would like him to go to school to be mainstreamed. And let's see, we don't have to go through every detail. He spends about 80% of his time in a regular school. Tired. He's pretty traumatized. I'm going to just kind of blow through some of this, but I want to give you some of the ideas. He's a fun guy. He's adorable. I mean, when he's bad, he's very bad. When he's good, he's very good. And most of the time, he's very good. Charming, funny, playful, affectionate. He can be very stubborn. He likes to play being in jail. He loves to play sports, but he's not very coordinated. He does do Special Olympics. He has no kid friends, plays with his cousins, but as everybody's getting older, his normal relatives are having more trouble with him. He's got a couple of friends. He's doing Cub Scouts. He likes to play chase, and that'll work for a while, but then the other kids are going to outgrow it. He likes to be on the trampoline. I'm going to just blow through this. I just wanted to give you an idea. You know, it's an interesting case. He's very scared going into new situations. Let me back up. I love this. Kids who are learning to express themselves. He's afraid to get his shots. We had to restrain him, like he's at the port and all of that. I am angry. I'm using my words. I don't want to do it. And then he just did it. He's interesting. I love how there can be ways that, although they're intellectually delayed, they can be really quite sophisticated and not delayed in other ways. So he's really having trouble. He had a teacher, changed her hair. He gets really attached. He finds some attractive young instructor. He's definitely a little romantic, and he can latch on. And then if she changes, he freaked out, didn't want to go to school. He's rigid. He does not like change. So where I'm starting to listen is, who is this child? What makes him him? And these are some of the traits: his rigidity, his dramaticness, his amorousness. I want to know, who's he separate from his diagnoses? If anyone's sick, he gets really upset and he wants to punish them. If somebody's acting in a way he doesn't like, he's manipulative. He rejects them and chooses the other parent. But he loves the family. He loves to be all together. He loves it. He wants to have a group hug all the time. Temperature, he's a nerd to it. He's got some funguses. He's got a little bit of a rash around his face. We have the constipation. Constipation can be a lot of things. He doesn't have an urge, and then the stools build up and they're large and uncomfortable and painful, which does make a lot of children then resist having the bowel movement. His food cravings, doesn't like bad weather. It's interesting that he's messy, but he likes to dress up in his fancy clothes too. And that's relevant because I'll tell you, I gave him Nux vomica and it was brilliant for him. So although we can think of Nux as tidy, he does like to cut a sharp figure in his Bronco outfit, but being messy did not keep me from it. So let's see. Then I meet him in the office. And I've saved a topic to talk about. We saved sleep to talk about because I want to have something to talk about with him in the office. It's not threatening. If I want to just start talking about how he's violent, that would be a bad entree. So I've saved something that would be kind of neutral. And we talk about that for a while. And I mostly want to watch him in my office. And he basically does not want to interact with me. He's experiencing me as intrusive. He doesn't want to answer. He wants to get up on my table. I ask him to take his shoes off and he hisses at me, which was kind of funny because he's 10. He wears his coat the whole time. And then I've also seen him in action on the Zoom at home, where I've seen him be affectionate and funny and smiling. So I know he's just feeling a little threatened here, and that's all interesting. So I present this case because it's really important to separate the boy from the downs. It's really important to know what's the chemo and what's him, and to know what's usual. And it's really important to separate out the interview so the child's not unduly stressed. And I will make the interview with the child as long as short as possible. Watching how he responds on the Zoom and in my office, super important, paramount. I often find children are like, oh, tell Dr. Jody what you think. And they look at them like, don't tell me what to do. And what's more important is not so much that they answer the right question, but that I get to watch how they are with questions and with their parents. That's the most important. I think, would like to blow through to the end and then take questions. So I want to talk about adolescence. Adolescence is a new idea. It's since the Civil War. Previously, children were just like small adults in some ways, a little labor force. And since then, we have different laws for children and teenagers where they have to go to school, how old you can marry, voting, drinking. Like, this is a relatively new idea about adolescence, and it's characterized by these 5 things. Growth and development, the fact that you're not a child, you're not an adult. This in-between ground creates lots of unknowns. Increased decision-making, increased pressure, and the search for self. These are like the 5 technical descriptions of adolescence. I like the Berenstain Bear ones. I know that they're not like PC, but privileges and freedom versus responsibility. And the capacity for reproduction and to have sexual feeling, but not maybe maturity about how to run all those channels. So these are the things that characterize it. And what I find, what's going on in adolescence in our time, we have things that haven't always been so present. Intensity of peer pressure, drugs and alcohol, violence, eating disorders and body image, social media presence and bullying. COVID just really, it's a whole new thing. Anxiety and isolation, dating, sexuality, sexting, suicide, 3rd leading cause of death in 15 to 24-year-olds, with accidents and homicide before that. So this is daunting, and this is the reason I want to prescribe for any teenager who wants me to. So taking the case in a teenager, first thing is, do they want to be there? If they don't want to be there, it's very tricky. So that's one of the things I want to discuss. Even though they don't want to be there, Are they open to me trying to help them? I have to establish trust. And the way to establish trust is to be trustworthy, to keep their confidences. If I'm talking to them alone, I want to get permission to discuss things with their parents. Do I see them with the parent in the room? When I was initially studying homeopathy, it was always see the child alone, see the parent alone, see them together. And things changed in a world of sexual abuse and lawsuits that for my own self, almost always prefer to see them together unless they request it. And that's for a few reasons. If there's things I want to talk about with the parent, I'll have them call me. We'll talk alone, or I'll meet with them alone. I'll have them write me some essays. And I want people to be comfortable, and I don't want to embarrass or shame them. And I'm just kind of blown away what people will sometimes say about their children in front of their children. So I say, let's be together for everything that's comfortable together, and then we can talk separately as is appropriate. And then I make sure I explain what is a homeopathic interview and why do I want to know these things and what do I want to know. And then I tell them they don't have to tell me anything they don't want to tell me. And that is so relaxing for them. And I always say that right away. And if I ask them something they don't want to talk about, don't. It's fine. I always think it's like a hologram. If I have this many parts of it, I'll get the rest. If they don't want to see me, many of them will lie, especially if they're a little younger and feel very clever about it, and often will withhold. And I just think that's okay. And if they want to, they'll be more forthcoming. Sometimes they'll be plenty forthcoming with their parent. And I've been mostly seeing teenagers with their parents recently, and maybe it's who's self-selecting to see me, but very expressive and very comfortable with their parents. It's interesting. So we want to watch that dynamic between the parent and the child. It's also interesting doing telehealth now where I'm in their house. It's been amazing to see, oh, well, I'm in your room, I'm in your home, and that gives me information for the case. So I want to quickly go through this case and really quickly, but basically, mom tells the girl that she wants her to see me because she has a cough in the morning. Some sticky mucus, and in the winter she coughs a lot in the mucus. X-rays are clear. I had asked about the liquids. So some background on this child. She was adopted at 2.5 months and needed a nebulizer as an infant. Her birth mother was on drugs when she was pregnant and when the child was born, and had 5 previous children. She gave birth, left the baby at the hospital, who then went to foster care until the mother decided what to do. And then she was adopted by this family who has several other adopted children. She needed speech therapy. She had trouble eating. She needed feeding therapy. And while she was with her family, her mom got cancer and she had to live with her grandmother for a while. And then her grandmother died. And just another thing of note in her history is she walked at 9 months, which is quite early. So she's precocious in some ways and has a somewhat intense history, just like our other little guy. This girl, she's sitting on the couch with her mother. She's not looking at anybody. She's very quiet. She's very hesitant to answer my questions. She does not look happy about this situation. And she looks much older than 12, as many teenage girls do. I mean, she's preteen, and every time her mom says something she doesn't like, she sneers, rolls her eyes. In contrast, mom's trying to make her be more upbeat by being more upbeat herself, and it's creating a funny little tension. We talk a little bit about skin. I don't know how we got there. I'm thinking about allergies and her cough. They do have some dogs. They have a dog. She bites her nails. She writes on herself, wants a tattoo. She tells me she's loosening up because she laughed when her mother said that about the tattoo. And I learned that she liked art. I said, what do you like about art? And then she opens up, she starts talking about it. And I asked her to show me, if she would, her drawings. And it's an amazingly skillful drawing. She's very talented. And it's very cute little snake that's squeezing lemons. It's like a citrus squeezer snake. So she's got a sense of humor and she's very talented. We talk about her digestion. She's on a serious junk food diet. She drinks about 24 ounces. I'm trying to understand why she's coughing. Is she dry? Does she have allergies? But the real problem, and the reason the mom wanted me to see her, was that she's completely sedentary. She used to be a really active, outgoing, busy child. She did gymnastics. She ran around and played with her friends. She'd be out all day up till dark. And she just had a blast. She was really active. And then during COVID, her best friend across the street moved and she wasn't in school. And then she just wanted to lie around the house. She didn't shower. She didn't brush her teeth. And, puberty is one thing, but, what we have is she got, her friend left and she got isolated and she just collapsed into herself, which I think was, the heart of it. And let's see, she slept pretty well, cranky in the morning, snoring, TNA. So she's got fears. She's not very angry. Her mom says she internalizes. So they're sitting next to each other and mom's saying these things in front of her and it's fine. It's just fine. She says how she was really chatty before COVID and now she's very quiet. Used to be the host, loved being around people, was a social leader, was inclusive. And now she describes to me that she feels awkward and weird around people and that she doesn't know. And that she just feels like, you're just kind of there. And she is speaking third person there. And that, you didn't get to see people at school and you wore masks at the stores. And, I'm already know where I'm going homeopathically. I asked a confirming question. Light doesn't bother her eyes. When she's sad, she doesn't want to be around people. She has gotten her period. So that's just a little overview. It was kind of unstructured and I did get a lot of other information. So she's got this morning cough with a history of a bunch of respiratory issues. This is Colorado. It's super dry. She's, I think, depressed, withdrawn. And I think that what happened in COVID triggered her early separation, adoption, abandonment issues. I also think she's on a terrible diet and she's really deficient. The obvious remedy, Nature Mirror. I'll just tell you that this worked gloriously. She's an outgoing, happy, fun child, social, running around, like completely reversed. I think being well nourished got her energy back. But what I want to say about teenagers is when it's good, it's very good. And it's such a fabulous opportunity. And so many of young people are hungry to be seen and heard in the way that we see and hear them. So, yeah, this was a very, just like you want to do homeopathy because she got her life back. That I don't want to be intrusive, that we just talk about this or that. We'll talk about her cough or mucus. And then when we got to the art, then we could talk because then she invited me into her world. And that if you can find that point of connection, if you can be interested in it, then people like to be seen and heard mostly, unless it's, a different kind of case. So be flexible, let it roll. You can come back and cover all your generals and bases, but be open to just what makes them comfortable so that the case can come forward. You can go back and get all the details. Make it comfortable. You can go back and get the sensitive data. Build the relationship. So now I've it hasn't even been that many months. It's maybe been, it was transformative. It was just so fabulous. And so now she's happy to talk to me, and she knows, she understands what happened, and she wants to make sure I understand her and we can make it work. So that's what's important about this case. A couple of things. I treat quite a lot of children with mental illness, and sometimes I don't see them, is what I wanted to say. I mean, literally, I've never been in a room with them. I'm thinking of some brothers. Both brothers have mental illness, and one was a child, very violent, very sexually inappropriate. He's about 12, on medications. And I met him once on Zoom, and I've never seen him again. I've done the rest of it through his parents. He doesn't want to see any practitioners. And we finally got to the remedy that I think is really right. He did great on belladonna, but then the peculiar was this very strange sexual speech and offensiveness, gave him hyoscyamus, and he's just doing great. But I wanted to say that there are times when it's okay. I can take the case through the parents, that can work. Eating disorders in teenagers, boys and girls. They can be a wrestler if they're a boy, or the new topic is bigorexia. They want to get huge. Dangerous. You should know that eating disorders like anorexia is the most life-threatening mental illness. So make sure you get them help. And what I wanted to say, that working with adolescents can be some of the most gratifying work, because a well adolescent, they're like coming alive. They're exploring, oh my gosh, who am I? Who is this world? And they want mentors. They want elders. They want support. And I want to say they can be the absolutely most exciting people to work with. So I think if you can prescribe for children, you should. So I haven't left very much time for questions. Let's, if you want to ask me some questions, I would say unmute and ask me anything you want.
Jody, you said referral for anorexia, or you said get them help for anorexia. Is that a referral?
Yes, yes, you want,
okay.
Well, I might prescribe for them, but you want an eating disorder specialist. They might need to be inpatient. It's it's just startling, but if they end up nutritionally deficient at a young age, it can affect their whole life, you know.
Thank you.
Yeah. Any other questions? All right, then. Well, thank you for joining me. I've tried to just give you a little idea of some things to think about. Hopefully there'll be something for everyone in here, and some take home that will help you. If you have questions, you can feel free to email me. Oh, you're welcome. Let me address that question about why I wouldn't give more calc phos. Honestly, I couldn't get the parent in here. So those are the difficulties of our time. Yeah. So yeah, like I said, hopefully you already know about taking cases, but be some little tidbit for everyone. All right. Well, like I said, if you have a question, feel free to email me, or what else? I have a few more chats here. You're welcome. You're welcome. You're welcome. I love treating kids. It's been the joy of my career. All right. Have a good night. I wish you all well. Treat children. Bye-bye.